So we were hoping that the Deputy Chief Medical Officer for Wales, Dr. Gill Richardson, would be able to join us. She's got the lead in Welsh Government for the COVID-19 vaccine programme here in Wales. And she's hugely experienced and also has a real interest in global health, having worked overseas. So when we do get her, hopefully she'll be able to give us a kind of global overview. But while we're waiting for her, what we thought would be really helpful is to hear some people's personal experience. I'm absolutely delighted that we've got Dr. Beryl D'Souza from the Good Shepherd Healthcare Initiative in India, who the Good Shepherd Healthcare Initiative focuses on bringing human rights to the most vulnerable people through medical services and preventive treatments. And as we've all seen, India has been facing a massive challenge with COVID-19. So I'm immensely grateful for Dr. Beryl D'Souza for being able to join us and to give us her perspective on the challenges of COVID-19, particularly what's happening around vaccine, access to vaccine and equitable access to vaccinations. So Beryl, can I hand over to you?
Well, thank you, Kathrin. And yes, it's such an honor to be with you kind folks. And as Kathrin has mentioned, you all sound like you're just next door. This connection is very good. I'm going to be just sharing a little bit about my own experience. I'm not an expert in the matter of vaccine rollouts, etc. I'm a pediatrician and working with a community health program that is very bottoms up. So as Dr. Sally, who's a part of our team here as well, we have projects spread across rural India in very hard and difficult places like Bihar and Rajasthan. And so our experience of the vaccine rollout is quite valuable in understanding what's working and what's not working in India. Let me give you a summary of what has happened in the last 6 months. Our program began in January with a very ambitious plan to vaccinate all by the end of the year. That was the intention of the vaccine rollout program. The best thing that happened was that the focus was first in vaccinating the health workers, as it has been in other countries as well. And so the drive was available and open for health workers across the country. There was one major challenge to it, which is the digital platform-based program that it was. So everything had to be recorded online. And if you have good access, which most of India should be, because we're known as the high-tech city of the world now, it should work. Having said that, it's not really, the reality and the truth are two different things. And so it would hope to work, but there were lots of challenges to that. And so with the digital platform, even here in the city, the clinic where I work at, we have a staff of 20 and only 2 people were actually called into the government's vaccination program. And the rest of us were waiting for a few weeks, and it became more weeks as we waited and realized that we were missed on the list by some, data entry error or whatever. We're not sure what actually went wrong. Thankfully, because our clinic is well networked with the local government infrastructure, health infrastructure, we were able to then contact an obstetrician who worked at the government health center and is also a consultant at our clinic, who said, yes, please come in and get vaccinated at our center. She was actually running the vaccination center and she herself hadn't taken the vaccine, but she was able to provide the vaccine for myself and my team of 18 members who hadn't the vaccine. And that was really excellent. And watching us take the vaccine, she said that most of the staff at the government hospital hadn't really taken the vaccine because the first person who got the vaccine, a staff of that government center, had an anaphylactic reaction, which happens very rarely, as we all know. And because of that, everyone was sort of skeptical, even though they're medical people and doctors and nurses and medical staff, they were just too scared to take the vaccine. And as they watched our team come in willingly and, eagerly seeking the vaccine, it gave them the courage to then go ahead and take the vaccine. To make a bigger story small, what happened was we all got the vaccine, the first and the second dose, right in time before the pandemic second wave hit. And we were really grateful that we had the vaccine because that really helped us going. Having said that, our rural health programs were not so successful in getting the vaccine. As I mentioned, we have community health programs across the country. And so our community health workers who work in very vulnerable rural communities only 40% of the 150 people that work with us were able to access the vaccines. And again, here the major deterrent was the digital platform. And then, of course, there are a lot of barriers in the village, which just comes to literacy and money and, the right networks, caste, gender, and all of that, things that shouldn't happen but do happen in India. No, I think obviously around the world. And so when the pandemic second wave worked, the health workers who were out there, a lot of them had significant effect on their families. We've had staff who lost family members, and not being vaccinated was a real deterrent against them providing good services. And so that just again demonstrates the gaps in the inequitable health system. Uh, After that, the health workers, the government opened up the vaccines for high-risk communities, so the above 65 and then the above 45. And at that time, it was seen as a free-for-all program, meaning that 75% of the vaccination was owned by the state, by the centers, and then 25% was private. Again, there was a lot of chaos. Initially, there was a lot of misunderstanding and anti-vaccine theories about why you should or shouldn't get the vaccine. And then when the pandemic second wave hit, there was a lot of demand for the vaccines. And at that time, there was an acute shortage, as was illustrated by the media, that vaccines were not available. You could buy vaccines in black. The government centers that were providing the vaccines were over. It was full. It was like, a riot or complete chaos. And I was telling a friend that, in our personal experiences, we noted that the government centers that were doing vaccines had the COVID testing line and the vaccination line just side by side. So if you go in there and if you didn't have COVID while you were waiting to get your vaccine, you would very well get COVID, as has been, the experience for many people that they've actually went to the center and got COVID. Some of them succumbed to the COVID. So that really was a real challenge for the people in the communities. And then again, the availability in the private healthcare, where if you had the money or the right connections, you could get vaccinated. It didn't matter whether you were high risk or not. We've had film stars and ministers' sons, etc., who got vaccinated, and vulnerable communities that didn't get vaccinated. And there was such a bit of mob culture in the middle of the second wave, where people were struggling for hospitalization and oxygen and beds, and vaccines were seen as such an emergency, and it was not available, that the vaccine tycoon Poonawalla of the Serum Institute actually fled to the UK, and I think is still there. Currently we have 2 and now a third vaccine that's available, and again there is a shortage. Countries have offered to provide us with free vaccines. I mean, the US has said 1 million doses. So all of that makes sense in a time where we realize that unless everyone is safe, we are not safe, right? As it's been said again and again. So in summary, there is an inequitable system of vaccine rollout in our country, and it's been very costly, both to those who are vaccinated and those who have not. So the rural health divide, this digital platform, the cost of vaccination, it's not freely available, caste and economic barriers that prevent people from getting vaccinated. So I'll stop now, and I'm happy to answer questions if required.
Thank you very much, Dr. D'Souza. That's very, very clear picture of what's going on from your own experience and what you've heard. So it comes across quite strongly, the kind of chaos of it's bound to be chaos to some extent, as it has been in every country, because we're all responding so quickly. But that's a really clear picture. I wonder if people have got questions, if they can put them in the chat. If I can hold the questions for now, Beryl, because I'm aware that Dr. Richardson has got limited time, and we've now got her in. So if we move to Dr. Richardson, and then maybe we can take some questions after that, if you're happy to stay for a bit. Is that okay with you? Brilliant. Thank you ever so much. Gill, thank you. I'm sorry you had difficulty getting in, but we're delighted that you're here now. I've kind of introduced you before you got you arrived, but just to let everyone know, Dr. Richardson is the Deputy Chief Medical Officer for the COVID-19 vaccine programme, as well as having a very broad and long experience in public health, both in the UK and a long time ago overseas. So you really do bring an expert voice. So thank you very much. I think you've got some slides. I don't know if Beth, you want to show them all?
Yeah, is Beth able to show them for me? That's lovely. Thank you, Beth. That's great. It was just really helpful hearing Dr. D'Souza talk about just the on-the-ground difficulties and the huge infrastructure needs and sort of universal healthcare needs that underpin delivery of any vaccination program, and just very aware that those basic things, they're not universal at the moment, are they? So what COVID has done is it's thrown in sharp relief existing inequities, and that has been the case in the UK as well as elsewhere, but obviously much more so, and just really very, very sobering to hear, the experience on the ground there in India, Dr. D'Souza. So next slide then, if we just look at the global context, then you can see that it is an unequal sort of world. It's unequal in terms of the new cases, which are rising in certain parts of the world, receding in others. But in particular, you'll note that the countries in dark have the most change in the last 2 weeks, and you can see that the UK isn't amongst that, and that's because of the Delta variant and the fact that that is now becoming the dominant variant here. Next slide, please. You can see that for coverage with single dose, our WaAHLN data has a fantastic amount of maps and tables if you haven't discovered that resource. But you can see that for single dose coverage, again, it's very unequal, and it's not always where there is more disease, as we know. And very much you can see that it's the US and Canada, it's Western Europe and the UK, and then looking over, towards Russia and China that have the high incidence. But some of the sort of real success stories are the tiny places like the Malta and Gibraltar. But then, of course, they have access to supply. And that is the main cause of this variation, is most of Africa, as you can see, has not had supply. Okay, next slide, please. And of course, that's reflected also then in the fully vaccinated, which just further compounds the problem. And you can see that Chile has actually got quite a high percentage of the population vaccinated, but what was used there has been the Sinovac, and that only had a 3% effectiveness after the first dose. So in fact, they continued to have quite an upsurge in cases even after they began their program. And I guess this is something also to say that the vaccines being used throughout the world are all at various stages. Some of them have had phase 3 trials, some of them have not. Some of them, the phase 3 trials are actually the deployment. So it's an unequal world in that respect as well, in terms of the research and the efficacy and safety profile that we know of for the vaccines. Next slide, please. So just obviously, about the COVAX initiative, the key players, including Gavi, which includes, the Bill and Melinda Gates Foundation and others. And this is something which, just as Dr. D'Souza has said, no one is safe until we are all safe. So these coalitions are working to try and increase the numbers of vaccines that those that are in possession of technology or manufacturing capacity can give to those countries that do not yet have that capacity. And so part of this is also looking at the patent regulations and also looking at the cost per vaccine. So as you know, the UK Oxford University entered into an agreement with AstraZeneca to make sure that there was an affordable vaccine globally. And so that is the low-cost vaccine able to be stored in fridges. But obviously we have a lot of other vaccines as well. Next slide. Thinking about in-country variation, this is quite stark in some places of the world, and we've heard about, those with money can get it in India, and in certainly in other countries there are very sharp divides. The situation has improved with regard to Palestinian populations in Israel since this slide, but it was really a very unequal distribution back in March. And of course, that is a bit of a false reassurance if the population is left behind in any part. So it's definitely something which, although it was their initial policy, this has changed, and now there are moves to increasingly vaccinate Palestinian populations. Next slide. In Wales, we also have our differences, and they can be either through ethnicity or through socioeconomic deprivation. We've been able to track the differences in the vaccination uptake rates between those of various ethnic minority groups, and pleased to say that the discrepancies are narrowing, but they're still quite marked. And in one age group, 50 to 59, they have increased. And a lot of this has been due to some of the population groups that perhaps have cultural considerations, concerns about vaccine characteristics, and whether the vaccine is allowed for certain religious groups. Also, language issues and accessibility problems. So we've been working quite hard to make sure that we are doing outreach into the communities, including single language webinars in Asian languages and African languages. But in fact, the part of the population that is left as still an area that we're concerned about are middle-aged men, very much in the Black African and Black Caribbean communities. So they still need quite a lot of reassurance, and there are definitely misinformation, narratives that they have believed. Next slide. Just to show the socioeconomic gradient, if we divide our population into fifths, most deprived and least deprived fifths of the population, there is a discrepancy across the board on the age groups. The discrepancy has shrunk, thankfully, since the beginning of the programme, and is less for the older age groups now. We're still making sure that that does not get reinforced in the younger age groups. Next slide. So obviously you'll know that for prioritisation, the UK government felt that they needed to be independent clinical advice on what the strategy should be for whether somebody was eligible and the order in which they were eligible, so that the JCVI produced some very clear guidance on who actually was most at risk of hospitalisation or of serious illness and death. And that was very much based on age and clinical vulnerability. They looked at other potentials and apart from prioritising the health and social care workers, they didn't feel that an occupational risk model was workable. So I know that that has been the case for some countries, but that was decided against here. So it's very much been on an age base, which has proved to be quite a fair system, I think, on reflection. Next slide. Thank you. And then for phase 2, we moved down to the parts of the population that weren't so much at risk of hospitalisation or serious illness, but they obviously, to complete the herd immunity, that was worked through. And again, they reconsidered, and JCVI again said an age basis was the most workable and the fairest. Next slide. So in Wales, we've got a vaccine equity approach. There's already quite a lot of legislation here with regards to protected characteristics, so that you should not be discriminated against on basis of age, gender, ethnic profiles, physical disability, sensory impairments, learning disability, and so on. We also have a socioeconomic duty as the NHS in Wales to look after any individuals in economic deprivation. And then there's an inclusion health agenda for those groups that are underserved traditionally. Next slide, please. And so earlier on this year, we published a vaccine equity strategy, and this looked at the 4 areas that we would like to be involved in: tracking and surveillance, looking at the operational aspects of delivering the programme that needed to be changed, and communications and engagement on a bespoke basis with the parts of the population we knew needed attention. Next slide. And so the groupings of the people have been put very much in 5 groups. So there's 5 subgroups to the Vaccine Equity Committee. Those with physical, sensory and learning disabilities, people at economic disadvantage, people from ethnic minority groups, people experiencing homelessness, substance misuse or severe mental illness, and then asylum seeking and refugee individuals, and also economic migrants. Next slide. There's quite a lot of sometimes there's issues that affect all, or affect 2 or 3, or just 2. But we've been looking to basically try and identify, understand, and apply our actions towards each group. And we've done that by mapping the vaccination journey from the minute somebody is notified, whether that notification is actually accessible to them. People are invited in Wales for their vaccination, and whether there needs to be any tweak along that whole pathway, including guide dog access to clinics or whatever it may be. Next slide, please. And so it's very much been a kind of plan, test and adapt, and each of the groups has been working on an action plan. Next slide, please. Some of the key enablers that have helped, I think, with looking at the delivery in Wales has been very much looking at the various settings and seeing what adjustments need to be made in each setting. Primary care already saves a lot of information about how people would like to be approached, what language they would need. But obviously the new settings that we were establishing didn't. And so there's been quite a lot of catch-up for those. Next one, please. Just a little note on pharmacy logistics and how this is another thing that can really reinforce inequity, because certainly for deployment of the mRNA vaccines, you need to have, well, for Pfizer, storage capacity at -70, and a country such as Wales, we only have 2 places where we have storage capacity such as that. So we have to work out the transportation. Each vaccine is only allowed a certain number of transfers. So logistics are a huge part of the planning, but that creates an equity if you haven't got the ability to store vaccine. And of course, even Moderna, the next mRNA vaccine that we have, that's the -20 storage. So all these things, pharmaceutical infrastructure is really a key thing which will drive inequity unless addressed. Next slide. So lastly, there are certain foundations, universal healthcare, as you've all been working towards, and we know that WHO very much have been at the forefront of calling for the vaccination delivery, whether it's free at the point of delivery to the person through either an insurance back system or a national health service type model. We've heard how if you have money, you can advance yourself up the queue. Otherwise, the cold chain infrastructure and the monitoring of that, as I've said, and then also the supply of safe consumables, looking at needles, syringes, diluent, making the most of each vial of vaccine. Actually, there are certain needles, with very low dead space that you can extract more vaccine for your population. So having unequal access to the right consumables will reinforce inequities. Workforce and training, obviously a feature, and the IT infrastructure, both for capturing and also for invitation or ensuring that people are invited for their doses. And then, of course, looking at surveillance and aftercare. So I think that it's certainly a challenge. It's a challenge here in Wales, and I think it's a global challenge as well. Thank you. That's it. Thanks very much.
That's brilliant, Gill. That's an awful lot of information in a short space of time. There's been a couple of comments that people would like the slides, so I think we can do that from all the speakers. If you're happy to do that, we can share that with participants so they can go back and have a look at that information. And also, because it's recorded, you can go back and see some of the bits that you want to review. So I know we've got a little bit out of order now, and I know that you have to go, Gill, but you're very welcome to stay as long as you can, because I think it's as you pointed out, there's some things that are common in all countries, that kind of very systematic approach to how do you run a vaccination program, the logistics of it, and how do you make it equitable, how do you prioritize who goes first. And that's really important for the effectiveness and the impact of vaccination programs. So, sharing that knowledge. From the point of view of our audience, we're mostly people who are working in partnerships between Wales and sub-Saharan Africa. So we're quite small scale. I mean, and I don't think any partnership is particularly involved in vaccination programs. We're not at that level. But what is the two things I'm thinking people might be interested in is, one, what can you think of on a global scale? And there is that we, as citizens, we can really advocate for equitable access to vaccination. So, for instance, WHO have got a vaccine equity pledge. I'll put the link in the chat afterwards. You can go and you can sign up to it. You can contact your local MP, and if you're in Wales, if you have a Conservative MP, that's quite useful, because it will get heard by our current government. We want to put pressure on our government, particularly this week with the G7 meeting in Cornwall. So we can all do what we can as activists at that level, add our little voices. But at a very local level, I think understanding, like Beryl's very, very eloquently put, understanding what are the specific issues in the communities that our partners are dealing with. And I think as we go on and hear from Matthias as well, and from Jasmin, it's very much about what is it you can do at a very, very grassroots level to improve access for those who are most likely to get left behind. Because unless nobody is left behind, that really is, you know, selfish altruism, isn't it? We will all suffer, Beryl's quite rightly pointed out, unless everybody gets included. So hopefully we can learn lessons on a global scale, but also come up with some useful top tips for what we can do at a very local community level. So thank you very much, Gill, for that. I'm going to ask Beth. I can see that Matthias has joined us, but I'm not sure if Tabitha has. So
I believe she has. I let her in from the waiting room, so hopefully we've got both. Yes,
we have got Tabitha. Brilliant. Right. Okay. So we were going to have a little bit of a break shortly, but I think maybe if we can bring Matthias in, and then once we've heard from Matthias, maybe we could have a 5-minute break for people to go and stretch their legs and get a drink, and then we can carry on with Tabitha and with Jasmin. If people have got questions, please put them in the chat box, and we'll try and do all the questions at the end, so when we've got space and time. And also to close at the end, I'm really grateful that we've got Mark Davis here, who's a specialist registrar in public health, who's listening intently to everything and is going to do a bit of a summary and a feedback for us. So I think that would be really helpful to get the lessons learned at the end, and then we can share that with everybody as well. I'm assuming Tabitha is okay, and I don't know if Vito is here as well, but Tabitha Ndiaye and Vito Ndiaye, and I understand your surnames are a complete coincidence. You're not related.
Indeed. Hi, Kathrin. So I'm here. I think Vito is actually joining us at 1:45, just because he had something else on this morning. So he's not joined us yet, but I could make a start with the presentation, and then he could be there for questions afterwards, if that would be helpful.
That would be brilliant, Tabitha, and then we'll try and keep coming. We'll come back to you afterwards, Matthias, if that's all right. We'll have a 5-minute break after Tabitha, and then are you through there, Matthias? Oh, not yet. Anyway, Tabitha, over to you. I'm delighted that you could join us. You and your partner are working with a partnership in Senegal, I understand. So we're really keen to hear more. So over to you.
Great. I was going to try and share my screen to share some slides. So, oh, sorry, that's actually just Vito calling me. He might be having a problem signing in. Can I just see if I can just guide him through the sign-in? One minute.
Yep, that's okay. We don't mind. It's always a little bit chaotic. Oh. I mean, it'd be interesting to hear from Senegal, because I understand when we talk about vaccine equity, I heard yesterday that less than 2% of the vaccines globally have been given in sub-Saharan Africa. So the WHO target, just looking today, is that 30% of the population in all countries should be vaccinated by the end of this year, 2021, and 60% by the middle of next year. So that's the WHO target. And the WHO, IMF, and the World Trade Organization are calling this week for $50 billion to be put into a program to achieve that. 50 billion sounds like a really, it doesn't sound like a huge amount of money for the return that you're going to get on that, for globally, for us to get on top of this pandemic. It does seem like an extremely good investment. So we just hope that this week the G7 get behind it, particularly for low-income countries like sub-Saharan Africa. So Tabitha, you are going to tell us what's happening in Senegal, and hopefully.
Great. Great. Can everybody see that?
We can, yes, thank you.
Perfect. Yeah, so today I'm going to be giving a little bit of an insight into coronavirus in Senegal, and then also the relation to the vaccine rollout there. This is all in connection to the work that Niokolo Network, this is the organisation, the charity based in Wales, does in collaboration with our partners, our Senegalese partners, which is Kamba, a community-based association, and Kamba Film Group. And Vito, who will hopefully be joining in just a minute, he leads our film group work. So I want to just give a very brief overview of the situation in Senegal, and then I want to look a little bit about public opinion, because that really gives a background to the work that we particularly do, and then talk more specifically about our work. So first of all, I think it's helpful really to give a little bit of perspective actually on Senegal's response to the coronavirus in general. They've done very well in keeping case numbers low. So here you can see confirmed cases just over 40,000, deaths slightly over 1,000. I mean, there is likely to be a little bit of under-reporting, but really compared here on the graph, if you look at Senegal at the bottom, compared to Germany, Canada, UK, India, it's really, cases are very, very low. But then if we look at vaccine tracker, we see a bit of a different situation. So to date, there have been slightly over 500,000 doses administered. There are slightly under 70,000 people vaccinated. And you can really see the significance of that when you see that there's less than 1% of the population that has been fully vaccinated. To some extent, that is due to the availability of vaccines. So Senegal has purchased some vaccines from China and had a donation from the COVAX. But there is also but yeah, there isn't a huge number of vaccines entering the country at the moment. However, they very recently secured a patent to manufacture COVID-19 vaccines within country. And there are a number of funding, big funding facilities such as the EU who are looking to put funds into production of vaccines in Senegal. Into Africa, with Senegal being one of the leading players. So it could be that vaccine numbers are actually going to go up relatively soon over 2021 and into 2022. But then when we look and move to thinking about public opinion about vaccines in Senegal, so we carried out a small survey amongst the communities that we work in and also within our own networks in Senegal. And we found that when we ask people about the virus in general, we find that a large majority of people do actually consider the virus dangerous. And similarly, a large proportion of people are concerned about catching the virus. But that doesn't translate directly into the number of people who are willing or wanting to get a vaccination. So when we then asked about whether people would take a vaccine, we found that it was just a little over half of the population, obviously within our small survey numbers, were saying that they would take a vaccine, and a large number of people really saying that they were anxious or a little bit anxious about taking it. And actually, after carrying out this survey, I found an interesting study that had been reported. So this was carried out by Afrobarometer, with a sample size of 1,200 per country across 5 countries in West Africa. And here you can actually see some more concerning figures, whereby in Senegal, you've got 83% of the respondents were saying they didn't trust the government to ensure that the vaccine is safe. And 79% saying they are not likely to try to get vaccinated, even if those vaccines are available. And Senegal is really sort of sitting quite high up in comparison to even other countries in West Africa. And when you compare with other countries in Africa, West Africa is sitting quite high up on relative as well to that vaccine hesitancy. And so when you delve a little bit deeper into their results, you find there's not a huge effect of poverty. So people who are living in less poverty or people who are in more poverty, there's a high level of hesitancy across all those levels. Similarly, education doesn't seem to play a really strong causal factor in how likely people are. No matter how educated, how high a level of education people have received, they are still highly hesitant to get vaccinated. And then again, when we look at urban and rural areas, there's a high level of vaccine hesitancy in both. And when we spoke to people and sort of said, what is it that puts them off from having vaccines? There were certain trends or certain feelings that were coming across most strongly. They were doubtful about the efficacy of the vaccine. They lacked confidence in the new technology of some of the vaccines being developed, worried about side effects, especially in a country where health facilities are not as good as they are here, harder to access. A general distrust of vaccines, lots of stories about who's developed the vaccines and why, and then also a concern about contamination when having vaccines. And actually, and this is again from the Afrobarometer survey, they found when they were asked about prayer versus vaccine, a really high proportion of the population in Senegal thought that prayer is somewhat more or much more effective than a vaccine. So I think our taking from this was really there is a, for us, we're a small organization. We're not looking to get involved in the availability of vaccinations themselves, but we felt like this vaccine hesitancy was a really important issue to address. So just a little bit more about Niokolo Network. So we are a Wales-based charity working in Senegal. We very specifically work in communities which are based around Niokolo Koba National Park. So this is the picture on the left here is the main entrance to the park. And while people don't live within the park, all around the edge of the national park, which is huge, it's about half the size of Wales, there are small villages of between a couple of households to up to maybe 500 households scattered around with many different ethnicities and languages related to that as well. So where we've been working for a few years now in these villages, and where we felt there's a particular need is in a better transmission of accurate information, giving people the information they provide to make informed decisions, basically. And we've found that local language film is a very effective way of doing this. So we've been working with a local film group called Kamba Film Group, training them up to produce films. And then we've also been distributing these films using a pedal-powered cinema system, which you can see on the screen on the right-hand side. This is obviously prior to the COVID pandemic, so these village get-togethers were an effective method. But something we've had to rethink with social distancing restrictions coming into play. But so with this experience and with this to offer, I suppose, we felt that we could play a role in helping to get information out there about the virus, how people can respond to it, how they can get more information. So initially, early on, we produced a range of films. I'm just going to play a couple of seconds of a few different just to give a taste. So this is a film that Kamba Film Group produced using animation. So this has been particularly helpful actually in when social restrictions or when restrictions have been particularly heavy, because it's made it hard for the group to go out and do filming. And this is a work that people can do in an office with a single person not working close to other people. And this is done with French subtitles, but the voiceover is in Mandinka.
Tabitha, we can't hear that. When you share the presentation, you need to check a box saying optimize for sound. So if you stop sharing and then reshare, in the bottom left-hand corner, I think it is, there's a little box that you need to tick that says share sound.
1 minute. So share, I go to share and then I click on the screen.
Oh, sorry. When you go to share and it asks you to choose what you want to share, in the bottom left-hand corner, there's a little tiny box that says optimize for sound,
yeah.
like
optimize.
that.
Yeah, got it. Great. I'll try that again. So is that now? Oh, sorry, 1 second. So this first one, I'll just try playing that again.
Ndiaye menanya talal len si coronavirus kala nyame.
Does that work?
Coronavirus mu munti.
Yes.
Coronavirus mu kurang la timense yayi. Ase bodoto ke dun doto. Se yayi nyadi abe mo mena nina kata senyola. Kurang ni se fana muta. Wala adajol kata damen ni fana mata wala ase yayi fana na.
So that animation goes through really just the the most commonly shared WHO recommendations for how to avoid transmission of the of coronavirus, but does it in the language which is the first language of most of the communities who we're directly working with at the moment around the park. This second film was actually produced by Kambao Film Group, who felt that it was often young people who were particularly struggling to feel the importance of keeping social distancing, particularly with information coming through that young people were less likely to fall ill. So this was directed at really explaining why it's so important, and we did this as a music video. Oh, sorry.
ñamoon nga ñu daw gën ñu baam seet nga def ko yoonu tool li feebar la wala ay gént no covid bi sax dama mujj sof kenn talatu seeti kenn gisee bi sax dañ ko mujj off ko fi neew daa mujjee metti ba kenn amatul envie lekk soos nañu booloo rek mën a songu xeex fokk racisme coronavirus doy na guerre ku gëmul shit na la
and then there's another video as well. So this was also a music video, but with more general messaging going out. And this was actually without spoken. It was just made clear by the sort of key precautions, wearing masks, keeping distances. And we made another film about constructing tippy taps and hand washing in villages. So then leading on from this, we received a grant from Wales Africa and support from Wales for Africa Health Links as well, from some of the members there who gave us some really helpful support and guidance as putting this together. To first of all, distribute the films that we'd already produced more widely, try and get those to reach wider audiences using social media. And then to look at producing some material more specifically around addressing vaccine hesitancy. So this is the film that the film group are working on just at the moment. And it's not quite the final draft, but close to. So I will play the whole of this one. It's just over a minute.
Wow. Ndax jàngoroy coronavirus bii dafay wàlle te ñi muy dal ak ñi muy rey rek ngi yokk Sénégal ñàkk bi rek moo mën a taxawal mbas mi waa ñàkk Covid-19 bi moom ni muy demee ni ñàkk yëpp di demee rek waajal sa yaram tàggat ko ba nga xamante ne dina xàmmee jàngoro ji su ko defee bu coronavirus bi dugg see rek mu song ko faagaagal ko te du la tëral waa ñàkk bi moom ndax wóor na ñi seen xam-xam màcc ci wàllu wi ñoo ci liggéey ba mu dal kuréel gi nga xamante ne ñoo yore wérgu yaram ci àdduna ñu doog koo jaay ñàkk bi nag dina am jeexital.
So again, it's got French subtitles, but the spoken
wala nga mel ne ku liw
word is actually in Wolof.
ku song
This is because we're looking to distribute it more broadly than not just in the communities that we're working in. And Wolof, while it's not everybody's first language, it's the most commonly understood local language. So most people will level of Wolof that would mean they'd be able to understand this.
soo ko jëlee
and so this is really just going through some of the key questions that we felt people were asking.
waaye nag ñàkk bi dañ koy jël ñaari yoon ngir mu mën a gën a farlu gën a yàgg waa su ma ñàkkoo ba pare nag soo ñàkkoo ba pare nag nga gën a bàyyi xel nag ci di moytu ñooxoo tey takk sa masque ndax donte ka ñàkku nga ba pare feebar bi xëy na mënatulaa dugg yow waaye nag mën nga koo am te doo ko xam nga wàllu ko koo xamante ne ñàkkuwul vidéo bii Kambao production moo ko defoon leen ko jagleel ba beneen yoon.
And then just providing some more information about where people can go if they've got further questions or the Senegal-specific information line. And so we're looking to produce actually an additional piece here. Oh, I don't know if that's actually okay. We're looking to produce. So we're looking to produce one additional piece, which would be an interview with either a doctor or a religious leader, particularly thinking about the religious leader, knowing that people do believe a lot around prayer, and the power, the faith is a very important decider for how people act. And then also putting together some shorter clips or infograms that can be easily shared. And then we're looking to distribute these through mobile phone networks. So we're working with a local enterprise called Jokalante, which has got a communication platform, which means that we can send out a single message to multiple phones across multiple villages, and also get feedback back from that. We can also send vocal messages. And the idea is that we keep that up sort of relatively frequently, so looking at sending out between 10 and 15 prompts or reminders per month, because what we feel is that sometimes you can have a single video, but it's actually that recurrent reminders that really help to remind people or to change opinion over time. And then also looking to distribute it more broadly through Facebook campaigns, which is a very widely used social media in Senegal. And that's also with support from the Welsh Government Wales and Africa grant scheme, who we're very grateful to. And I think that's the end of the presentation. And so I'm not sure if Vito's managed to join and if I've gone over time.
He has joined us, Tabitha.
Oh.
You want to bring him on screen?
Absolutely. I don't know how I do that.
No, it's all right. I can do it.
Oh, so great. Thank you. Have I stopped sharing now?
You have, yeah.
Right.
Thank you very much, Tabitha, and if Vito is there. We were going to have a little break, but what I think would be really helpful, hi Vito, good to see you there, is I know Dr. Beryl de Sousa has to leave shortly, so I wonder if people have got questions for Tabitha, Vito or Dr. Beryl, if anybody would like to ask a question, just raise your hand. I can't see everybody on the screen, so if you look at reactions, and press a hand on reactions down below, or just shout out, just switch your camera on. I can see Mac. Mac, you've got a question? Do you want to fire away? You're first in the queue.
Yes, I did actually post my question on the chat. That question was, which vaccine is being licensed for manufacture in Senegal, and what company will be manufacturing it? And have they got relevant experience of producing vaccines?
So I think I'll take that, because that was actually just something that I was reading up as I was researching this yesterday. It's called the Institut Pasteur. So yes, they are one of the only institutes that are already producing vaccines in I'm going to say Africa. I'm going a little bit out of my my knowledge sphere here. I'm not a medical expert, but I think that they were saying that they're one of the few, or one of the only medical institutes already producing vaccines, just not the COVID-19 vaccine. And so that's based in Dakar, in the capital city.
The Pasteur Institute, is it?
Yes, that's the one. Yeah.
Okay. Yeah. They have the experience. Yes.
Thanks, Mac. Does anybody have a question for Dr. Beryl before we lose her? I hope she's still there. I'm just looking. Beryl, are you still with us? I think so. If nobody else is going to ask a question, have a think about it. But I'd be quite interested in that issue of trust that Tabitha raised, and whether that's something in your experience, Beryl, that people, where the vaccination is being offered from, particularly if it's private or public, is there a level of trust that's involved, and is that an issue in stopping people coming forward for the vaccinations? Do you know? I think we might have lost Beryl already. Is Beryl still there?
She's still there, but she's got a camera off and she's on mute, so it may be that she's away from her.
It might be that she just sent me a message to say she had to leave, so maybe she's left and just left her, is still connected. So, but we can always send questions on afterwards. Does anybody else have a burning question for Tabitha, Vito? Just, put your hand up or just shout out. Okay. Can I suggest that maybe that we have a 5-minute break, and then hopefully we can come back and try Matthias to hear from Uganda. So hopefully most people are back again. And I'm really, really disappointed that we can't get Matthias's sound corrected. So what I'm going to suggest is that we go to Jasmin, who is our very own expert from Wales, and I'm quite confident that some of the lessons that we've learned here in Wales are generalisable, and it'd be useful for us to take away and use in our own health partnership. So if we can go over to Jasmin, and then maybe Gordon might be able to pick up some of the feedback that he's heard from Matthias in Uganda, and then we'll have questions and discussions at the end, and hand over to Mark. So Jasmin, the floor is yours, virtually.
Thank you very much, Kathrin. Good afternoon, everybody. I'm Jasmin Chowdhury. I work as a senior practitioner with the Vaccine Preventable Disease Programme at Public Health Wales. It's a great honour to be here with you all today. So as this ongoing COVID-19 pandemic continues to spread around the world, with now more than 170 million confirmed cases and over 3.7 million deaths, there's hardly any areas in the world that's been untouched by this awful virus. And equitable vaccination around the globe provides us with the best hope for defeating this pandemic, but also for securing global recovery. So I know we've heard from Dr. Gill Richardson, and a lot of the areas that I'm going to touch on. She's kind of given us an overview with our strategy here in Wales. So while throughout the world there's been impressive kind of progress on the vaccination with COVID-19, scientists have come up with multiple vaccines in record time. Unprecedented sort of public and private financing has supported vaccine research. Thousands of volunteers have come forward for a huge global effort to get us here at this stage where we have a number of vaccines available here in the UK now and have been approved by the MHRA. We know from past sort of experiences of large vaccination programs that by their very nature, they risk creating a range of inequalities in uptake and access to the vaccine, especially when known in people who bear this burden of such inequalities are, for example, people who are not registered with GPs. It could be asylum seekers, refugees, Gypsy, Roma, traveller communities, homeless people. We also know some parts of Black, Asian, minority ethnic communities, and some of the people who live in the most deprived areas of Wales who sometimes can't afford to take the time off work to get vaccinated, or people, for various reasons, practical reasons, such as not being able to travel to access the vaccination site. So from the beginning, our strategy in Wales has been guided by this principle of leaving no one behind. And there has been, considering the paucity in the data and the limited knowledge and understanding we have about the perceptions of those affected by the inequalities in vaccination programs traditionally, there was a concerted effort to reach out to those groups right from the outset and to engage, through our activities, to engage and get an understanding of what their concerns may be around the vaccine, what would be their motivating factors. So as well as a number of sort of attitudinal surveys and to gather those behavioral insights from those groups. There was, we had sort of engagement activities going on parallel to those surveys running to gather some in-depth understanding about people's motivation and also the barriers. Sorry. So whilst the uptake in Wales has been and remains quite high, there are still a number of groups, as Dr. Richardson has mentioned already, and they go across all age ranges. And despite sort of receiving more than one offer, they remain unvaccinated. They still haven't taken up that offer yet. So while there has been, the uptake looks really impressive, and the figures are very encouraging in Wales, we know that there's quite a lot of work to do to ensure that we are not leaving anybody behind in the program. So in terms of looking at the learning from previous programs, we know there are some groups that usually are affected by those inequalities, as I've touched on already. And they tend to be, affected by sort of socioeconomic status, some of the minority ethnic groups, and physical learning disabilities or sensory disabilities, and people experiencing substance misuse or homelessness. So the Public Health Wales produces what we call the enhanced surveillance data, and these, alongside the research and the surveys, have been critical in helping us to guide and shape our work to reach out to those kind of inclusion groups. The enhanced surveillance reports identifies areas, as Dr. Richardson mentioned, in the cover, inequality gaps in the coverage. So at least, we've been able to look at for the coverage for at least one dose of COVID-19 vaccine, for example, between from different minority groups, and then socioeconomic deprivation groups in adults. And although those gaps are narrowing, there's still, as Dr. Richardson mentioned, there's some work to do, and there are some marked differences still continuing to exist. So I don't want to go into too much details, because you've seen that from Dr. Richardson about the surveillance data, but I just wanted to say that this is what's helping to shape some of the work that we're doing to tackle the gaps that exist. So whilst the engagement activities has tried to sort of, some of the traditional methods have been used through sort of consultation with different stakeholders. We've joined sort of Q&A sessions. We've had number and a series of forums with different stakeholders. We've also worked very closely with different organizations, third sector community groups and third sector organizations. And I wanted to share an example of a group called Muslim Doctors Cymru, who we've collaborated with. So these are a group of healthcare professionals from the Muslim community. And we know, from the beginning of the pandemic, the data, the surveillance data was telling us that people from BME communities were disproportionately affected by the risk and outcomes of COVID-19. And some of the insights around the perceptions and attitudes towards vaccination was telling us that some parts of, not all BME communities, were reluctant to accept the vaccine when one became available. This was going back towards the sort of autumn last year. So Muslim Doctor Cymru carried out a survey, working collaboratively with Public Health Wales. And we were able to get some sort of, people's intentions, some ideas about people's intention. And you can see in that slide there, some of the younger groups where we are now moving towards in terms of the vaccination program. There was quite a lot of sort of unsurety, particularly among the 25 to 34-year-old. So, and when we asked them, what would motivate them to take up the vaccine, people mentioned things like seeing friends and family, protecting others, a sense of duty to the society, the vaccines being one of the safest public health interventions that was mentioned. And then when we asked them about why are they unsure about the vaccine, so we've already heard about the sort of safety and efficacy, side effects, distrust in the government and authorities, and sort of perception and also personal experiences of injustices, failure of systematic failure to deal with discrimination in the past, and so some existing experiences. And these were highlighted quite often in the media throughout, as we were beginning to start the vaccination program. So in the absence of a coherent rationale for why some of the BME communities were disproportionately affected by COVID-19, these were matters of concern for some of the community about how unethical research with some of the ethnic minority communities and experiences of discrimination led to a distrust in government and authorities, influence their decisions then whether to go for the vaccine or not. Sorry, I seem to be freezing. Right. We've heard Dr. Richardson talk about the Vaccine Equity Committee. So this was formed to provide an oversight. So it brings the different stakeholders, including our health boards, the services, different third sector organization, community organizations, Public Health Wales and Welsh Government. It brings all the different stakeholders together to give an oversight and review the inequities, issues around inequities. The subgroups that, they feed into this action plan that's being developed to address some of those issues. And it's carrying out, it's looking at how we can work with primary care, secondary care and services, the vaccination teams, the local, and make sure that it's kind of tailored, the plans are tailored to identified sort of localized plans and localized needs. So, in North Wales, for example, it might be, we might have to work with different groups. It could be different age groups, different ethnic groups compared to South Wales, but the health boards there would tailor their, or make, would have a flexible plan around ensuring they can improve access for those communities in the local areas. So some of the examples I wanted to share is about understanding sort of localized targeted approach. So the, offering alternative to sort of auto-scheduled appointments, for example. So we've looked and worked with local organizations and stakeholders to ensure that the invitation letters, for example, going out is accessible. People with physical as well as sensory disabilities, how would they access this invitation? Is it accessible for their carers? Is it accessible for their family? And how they would then make those appointments, and if they wanted to contact someone for more information, how is that going to be made available? Those are the sort of issues and questions that will be that are usually addressed in those working groups, where we're looking at people who haven't taken up their offer yet for the vaccination, making those kind of reasonable adjustments as much as possible, being flexible around the delivery model and the booking system, allowing and contacting people, and not stopping at one or two offers, and continuing to offer has been agreed as a way forward to make sure that we don't leave anyone behind. Alongside those kind of practical and having a flexible plan, quite key to all of that is how we're communicating with all different groups and community and the population across Wales, and how we're engaging with those groups who are often, we don't reach out to us as well as we should do in some cases. So engagement.
Jasmin, sorry, I don't know if you're moving through the slides, but we're still stuck on slide 8 at the moment.
Okay, we should be on slide 11.
Sorry.
That's okay. Let me just stop and start sharing. That might help. So, can you see communication and engagement slide?
Yes, that's brilliant.
Brilliant, thank you. So yes, engagement with stakeholders to understand the beliefs and identify sort of trusted sources. So the message, we know is just as important as the messenger. So, going through Muslim Dr. Cymru, for example, and working closely with them, these are healthcare professionals from the community, and healthcare professionals are seen as a trusted sources, but they also are able to give people information around sort of any concerns around sort of ethical issues, or whether the vaccines are halal, the ingredients, what's in the vaccine, the content. Those sort of information has been really useful through. So we've hosted sort of webinars, joint webinars in different minority languages. So there would be a healthcare professional there, with an imam, for example, from the community. And those have been really effective in terms of reaching people where they're able to ask questions in their own language. Various easy access and WhatsApp, we use WhatsApp community messaging from Public Health Wales to, and our stakeholder networks. Would then share them with sort of service users, community groups will share them. So these are easy share messages on WhatsApp. Sometimes it's a video clip, very, very quick, a couple of sort of minutes video clips that can be shared quite easily through the social media. We also, on our website, there's a microsite kind of dedicated to the COVID-19 vaccination information. And we have what's called Recite Me software, which has about 100 different languages. It's also got the easy read format, Braille, and we are also producing information in British Sign Languages for, to make sure that all the information is accessible for all the groups that we want to reach out to. And getting those kind of constant feedback. So every engagement forums that I was in one last night, for example, with young people from BME, Black and minority ethnic communities, where we are constantly asking them about our messaging. Does it feel right? Does it sound right? And getting them to give us feedback on how we could improve on our branding, messaging. It has been really, really useful and helpful. So, one of the comments, for example, was how we need to have, with our images, for example, it needs to make sure that it's representative of the population that we want to serve. It's also about making sure that the language you're using is for young people. It kind of is relatable, and they can, access it quite easily on the platforms that they regularly use on social media. In terms of making, availability of the vaccine, improving availability and increasing confidence and trust, number of health boards and local public health teams have set up what we call pop-up clinics in community centers. So Bevan Health Board, for example, they've run weekend pop-up clinics in sort of, day centers for Gypsy Roma travelers, communities. Substance misuse clinics have been used for those kind of pop-up clinics. Outreach vaccination clinics for traveler communities at Chowdhury, where a community traveling or at a bus, a mobile bus has been used to go to points where it's easy access for those groups. So outreach vaccination clinics, a point of contact for homeless people, for for example, and vaccination hostels. Those have been hostels for supported accommodation has been really good way to reach people. And it's always been about sort of targeted and tailored approach for different eligible groups, such as young people, through our social media campaign. That's helping us to reach people. There's sort of what we call clinical script or scripts for reoffering the appointment and text messages. So using, it's in your hand, things like your first one in the queue now, your vaccination, NHS is ready to, the offer, your vaccination is still there. Those kind of text messages to remind people that the offer is there when they're ready to take it up. And making sure sort of migrant communities, for example, who may have concerns about their data being shared outside the NHS. So, reassuring them that their data will not be shared outside the COVID-19 vaccinations system, and those kind of you going through the trusted voices through community champions to promote those messages. And to get the information to those people has supported our community engagement efforts, and to hopefully improve the uptake among those groups. So I wanted to end with thanking all the colleagues at Public Health Wales for the all the data and the surveillance reports, Muslim Doctor Cymru, NHS Wales Informatics Services, Swansea University Sale, and all the stakeholders and community groups, third sector, individuals that we are working jointly with. Thank you.
Thank you. Thank you very much, Jasmin, for a very comprehensive explanation of why we in Wales have kind of taken on the challenge of equity, and making sure that the vaccine reaches everybody who could benefit. So there are a couple of questions that have come up, but can I start by asking you, of all the things that you've talked about, and I know you're quite an activist for social justice and and in low-income countries as well. So are there any ideas that you've seen put into practice here in Wales that have been effective that you think would be most transferable to a low-income setting, a low-resource setting?
Yeah, I think working through communities, trusted voices within communities. So, working with them rather than for them, rather than, based on our kind of assumptions that, people are going to, because quite often in our experience, what we find is people may not be taking the first offer of the vaccine for various reasons, and they're not necessarily against vaccines, they're not anti-vaxxers. The hesitation might be based on very valid reason about, sort of past experiences where there has been injustices, or some of the, sort of the unethical research that people have been part of. So the trust issue comes up very often, and through sort of people that they can relate to. So, even among family and friends, I quite often hear, I'm going to wait until somebody I know has had the vaccine, and then I'll decide. So it's very much, and their concerns are very valid, very understandable. And I think, as we should be going in, using sort of meaningful engagement methods with the intention to listen to, and, all the concerns, with the intention to be able to provide accurate and timely information in a way that is accessible for the community. And in countries where, I'm from Bangladesh, so, when I speak to family, friends in Bangladesh, friends in India, for example, we know that people are much more likely to trust people they know and are around them. And I think those are our, the most effective ways of reaching people.
Thank you. That the theme of trust is coming out quite strongly, isn't it? And from what Tabitha was saying, that it's about trust and trying to get people to counter all that misinformation from a trustworthy source, isn't it? So, is anybody want to ask any questions of Jasmin? If you just put your hand up or just jump in, you'd be very welcome.
Kathrin, there's a question further up the chat, which was actually for Gill, but actually might be relevant for Jasmin to answer, which was around what do you think some of us from BAME communities can do to encourage increased uptake in our communities? So that's what can we do on the ground?
Yeah, thank you. I think, what we have heard time again and again is about sort of the concerns around sort of safety and efficacy, first of all, and people having information. So one of the concern I remember right at the outset was about, what percentage of the people on the trials for the vaccines were from BME communities, for example. So how do I know, comorbid, people in ethnic minority communities, as we know, are affected by, or disproportionately affected by certain underlying conditions. So they wanted to know what would be the impact of these vaccines on those underlying conditions. So one of them was about the representation, and we know from all the trial data and where the trials have taken, there is a good representation of various ethnicities in the people who have taken part in the trials for the vaccines that have been approved in the UK. So the 4 vaccines that we have in the UK at the moment. So I think, as people from BME communities, and you just mentioned about the misinformation, Kathrin, we've also heard about how a lot of myths and kind of misinformation has been widely circulating on social media. So again, being, from, I'm in various groups on WhatsApp with family, friends, and these will cross, regional, national, geographical boundaries. So what's going on in India will often influence, a lot of our thinking and our decisions here around, around the pandemic, around the decisions that are being taken on sort of the public health measures, for example, and also around vaccination. So quite often, those sort of the misinformation, if they're coming from people they can be a strong source of kind of influence so it's what we avoided doing, I think, as public health professionals, is not to kind of give much attention to some of the myths and the misinformation or the inaccurate information. What we wanted to ensure is that we are able to get accurate information out to communities in a way that they can access them timely and make an informed decision. So this is why the WhatsApp messaging through communities has been really useful, I think. And I think the more we can, get communities on board to help us to reach, to disseminate those information, reach more communities, more individuals, that we will have, hopefully help people.
Thank you, Jasmin. I'm just thinking now, Claire put a question in earlier about the ethics of how we're vaccinating here in the UK. And I'm just wondering, I'm just going to ask Beth, are we able to do a poll? Can you do an instant poll so people here can take a view on that?
I'm not sure I am able to. I think it's something that needs to be set up before the meeting, but give me a couple of minutes and I'll see if I can do it. All right.
Okay. And then I'm aware Matthias is still with us, but he has sent me an email with what he wanted to say, and he sent it to Gordon as well. So I don't know, Gordon, if you've seen that email, because it might be, it would be lovely if Matthias could hear that being read out. I don't know, Gordon, have you got access to that?
I'm just checking. Oh, here it is.
Because you understand the context much better. So although Matthias can't connect to sound, he is here. So if you're able to, because he sent what he would have said. So are you happy to do that, Gordon?
Yeah, I'm happy to read it out, although I haven't read it through first. So this is this is high risk strategy. I'll just read in what I've got in front of me. Okay, it says, "Hi, Kathrin. It seems I'm having a big challenge regarding my internet connection, even though I tried purchasing what I thought is better, but is below what I wanted to share. So below is what I wanted to share with the others." So this is what Matthias is saying about Uganda. And just for information, Matthias lives and works in a place called Lowero, which is about an hour and a half, 2 hours drive north of Kampala. It's a very poor rural area, and it's where Care for Uganda works. And we have my wife Hilary here, who works with us, and Chris, John, and Ndiaye are also at the meeting. And we're all working in Lowero. So this is what Matthias has said. Uganda is currently in the second wave of the pandemic, with many cases reported on a daily basis. This upsurge has been so since March of this year. On the 4th of June, Uganda recorded 1,259 cases, which is the highest number ever recorded. So they're in a worse position now than they've ever been before. This wave seems to be very serious, affecting mainly young people aged 20 to 39. The current status says Uganda has 55,511 cases. Lowero district has 82 cases to date. And then he goes on to explain about the vaccination program in Uganda. Uganda received 964,000 doses of the AstraZeneca vaccine. So far, 748,000 people have been vaccinated. That's in Uganda. In Lowero, 7,000 people have been vaccinated. We are still in phase 1, targeting health workers, defense forces, police, teachers, people aged 50 and above, and other people 18 above with comorbidities like diabetes and HIV. And this is very interesting because I think it was Gill Richardson who said earlier on today that in the UK, the prioritization has been purely on age and nothing to do with occupation other than frontline health and care staff. But it's really interesting that in Uganda, health workers and then defense forces and police have been prioritized. And as you probably know, there was recently an election where the president surprisingly got re-elected, and many opponents were either shot and killed or locked up. Matthias goes on to say the challenge has been the availability of vaccines, as the vaccines were placed at health centre 4s, and that means health centres are graded according to size and capability. Health Centre 1 is the lowest, Health Centre 5 is the biggest. So these have all been put in Health Centre 4s and hospitals, but not been taken to local villages. So it has been very hard for people to travel and get the vaccine. He goes on to talk about myths and misconceptions. People say that the vaccine will make the men impotent, so they fear of getting it. Some say the whites want to wipe out and kill Africans. And some also think that COVID-19 is the disease for the whites only. And that's the end of Matthews's statement. He says, I am still on the meeting, but afraid you may not hear me. And he says he is totally sorry. Well, thank you, Mathias. I hope you heard your words coming through using my voice. But I just want to say thank you, Mathias, for contributing to today, but even more importantly, for all the brilliant work that you're doing in WaAHLN, and we are very, very grateful to you. Thank you, Kathrin.
Thank you, Gordon, and thanks, Matthias, if you can hear me there, and we'll do our best to try and get you into a future event, because it's at least we hope that you managed to make a contribution, and that was really interesting to hear. It's a shame we can't ask any questions. I'm aware we are just coming to wind up time at 10:02, so hopefully Mark is still with us. I'm very happy to do some closing remarks from what he's heard this afternoon. While Mark is speaking, we have managed to set up a poll to ask a simple yes or no question that Claire raised as a more nuanced question earlier on about the ethics of distribution of vaccination globally, because we are at the point where we're now talking about vaccinating. Well, we've opened vaccination to any adult, and we're talking about whether we move to vaccinating children. But ethically, what do we do globally? So we've got a poll that will come up. So if you do that, have a think about it and we'll leave it up there for a couple of minutes. But Mark, would you like to take over and reflect back on what you've heard? It's been quite an intense couple of hours, hasn't it? Quite a lot of information coming in, but it'd be lovely if you could do some reflection for us. Thank you.
Yeah, no problem. Thanks, Kathrin. And yeah, just a big thank you on my part to everyone that's contributed today. It's, as Jasmin said, it's been such a rich learning experience, lots of really, sobering stories, but also lots of really useful practical examples of how we've all addressed quite similar barriers, but in all different contexts, and really trying to work with partners and those at the community level to try and overcome some of those. So yeah, I've been given the task of trying to summarize all that richness. So I've tried my best. I've been scribbling along as we've been going through. So I've tried to condense it down to 3 key messages or points, really. So the first one for me was, I guess it keeps in with the theme of the title of this session. So I think it's clear to us all that there are stark inequalities in vaccine uptake. And there's lots of ways in which we can frame that. I think Dr. Gill Richardson gave a nice overview, and some of her images at the beginning showed, the inequity, not just within countries. And in Wales, she showed graphs of inequities within Wales, but also the stark inequities between countries. And I think that's where the real stark differences lie. I think looking at that graph there, I think there was uptakes in some countries of less than 1%. And then in, in America, Western Europe, vaccine uptake of over 50% at this stage. So, those are huge gaps in vaccine uptake there. And I think there's a nice quote that I think summarizes, where we should be moving forward with this. And I think Dr. Beryl introduced it, but I think it was being quoted quite a few times, the no one is safe until everyone is safe. And I think that's certainly being mentioned a lot of times, but we don't necessarily see that being put through into action. And I think Kathrin gave some nice suggestions of what we can perhaps do to support that idea, and how we can act on that. Globally, we can sign up to the pledge that WHO has put forward, and I think there's a link in the chat bar if people haven't seen that. And there's also things we can do more locally. So as Kathrin said, you can write to your MP and try and advocate and lobby for this, for this sentiment and that idea to actually be followed through in how we're delivering these vaccines. I think the second point for me then was just how complicated and complex this whole issue is. I think it's fair to say that there's been such rich discussion and examples this afternoon because it's so complex, and sometimes it's quite overwhelming really to try and unpick where to start, what can we do. I think we've heard examples from all sorts of different countries, but also different parts of the response in different countries, and I think it's been really nice to have the opportunity to share those examples. So thanks to those that have contributed. So Dr. Beryl in India at the beginning, and also Tabitha and Vito in Senegal, and then also Jasmin from the Wales perspective, and also Matthias from Uganda. It's just been nice to be able to see some of those similarities of the issues and the barriers, but obviously being very sensitive to how you address those locally. And I think that ties me into the third point really. It's very complex and everything's interrelated. It's not just one issue that fixes any particular barrier. But I think where there's real assets in what we've shared this afternoon is really listening to the communities and engaging at that community level. I think that's sometimes easily overlooked or sometimes not given the importance or emphasis that it deserves. But I think that's what makes the difference between having a plan or having a strategy and then actually translating that into something that actually works. And I think we've heard lots of examples of how people have tried to overcome those barriers. And interestingly, some of those barriers are quite, very much at the local level. I think the one that struck me at the beginning is when Dr. Beryl talked about the anaphylactic reaction in someone who'd had the vaccine, and that in itself created a lot of anxiety. And I think without that local knowledge, that local context, having that trusted voice to be able to explain the risks and being able to communicate that was really important, I think, in helping to make sure that that vaccine rollout and the uptake could move past that obviously very, very tragic scenario, but trying to work with those very local issues at the time. And I think, I think that ties into what Kathrin said as well about trust. All of this is very complex, and trying to make sure that people use their trusted positions and using whatever that may be in a different context. It could be health professionals in certain contexts. I think using faith leaders and faith groups. We've seen examples of that in Wales and other countries as well this afternoon. I think that's an important part of that community level support to make sure that all those high level strategies and all those things that we know we should be doing, making sure that actually delivers on the ground. But I'll leave it there and I'll pass back to Kathrin for any other closing remarks and wrapping it up.
That's great, Mark. Yeah, that's a really good summary. And I think that's an absolute key lesson, isn't it? That if it's going to work, it's got to work at local community level. And that's a theme that's come all the way through. And that's where health partnerships do have a role to play. Whatever we're doing, it's little droplets everywhere we work. It really is, the local is global. So we've got a poll result there, and I think there's a majority who feel that we should be considering sharing our vaccines that we've purchased here for our population and start sharing them before we vaccinate our entire population. There's got to come a point where we say enough's enough and start sharing it. So I think there's general agreement on that one. So that's interesting. So just to bring things to a close, I'm immensely grateful to all our speakers and contributors. we've had a few technical challenges through the afternoon, but hopefully we've managed to overcome those. And I'm just really pleased that we've had such a variety of contributions, and that there has been common themes coming out of them. So it's there's so much information in this that we will put the recording up when we can, and we'll let everybody who registered for this webinar, we'll let them know when the recording goes up, and then please share it with anybody and everybody. You know, if you think there are other people that would be interested in this, please do send them the link to the recording, and I think we'll be able to share the slide sets as well, because those are quite dense with information that would be really helpful for people. So thank you again to Hub Cymru Africa for doing all the practical organisations, in particular to Beth for doing all the behind the scenes work for this webinar, and the Hub Cymru Africa team for all their support, to the WaAHLN South Africa Health Links Network. So thank you very much everybody for coming, and keep an eye out on our website for any future events. We do have the WaAHLN Africa Health Links Network AGM on the 9th of July, so anybody's welcome to tune into that. It's only an hour and it's an update of what we've been up to, but do have a look at our website if you want to know what we're doing and what's coming up in future. So thank you very much everybody, and go and catch a bit of sun before it all disappears. Bye everybody.
Thank you.